toxic effects. It's about a patient, a young patient, who had a kidney tumor and received all sorts of chemotherapy. And I want to show you, this is the wrong slide, I want to show you now the images of this patient. Okay, and all you have to do now is look at left ventricular function. Okay, and keep in mind this is a young patient with chemotherapy, and obviously this echocardiogram was performed with the question, can chemotherapy be continued? Do we have any toxic effects of chemotherapy on the left ventricle? Okay. I mean, this is a very crucial question, obviously, because if you say left ventricular function is reduced, this would mean no more chemotherapy, which in some instances could really make a difference to the patient, obviously, because you cannot treat him for his tumor. So take a look at these images. Peristernal long axis view. I'm sure all of you also see that there's another feature on this echo which should not be there, namely this pericardial effusion. You can also see this here. This is pericardial effusion. Now the patient was very slim and difficult to image from the apical views. Those are the images I got, but I think you can quite nicely appreciate the left ventricle here and the function. Okay, this is the apical long axis view. Okay. Yvonne just asked a question about the pericardial effusion. Well, I would think it's a mild to moderately sized pericardial effusion. And in this case, aside from the fact that the patient has a questionably normal or maybe abnormal left ventricular function, we'll come to that later, the pericardial effusion might mean something else, namely that the patient could have a pericardial involvement of the primary tumor. Okay, so now let me ask you the question. Okay, the question is, how do you grade left ventricular function? Okay, you can click if you think you know what the answer is. Again, I'll give you a few minutes. And again, while you click, keep in mind that whatever you're going to write in the report will make a difference. If you say normal, but it is abnormal, and the patient gets chemotherapy, you might have full-blown chemotherapy-induced cardiomyopathy. Okay. Alan again asked the question. I'll answer that a bit later. I just want to finish the poll. Okay. I think I'm going to close the poll in 5 seconds. So if you want to answer, you better answer quickly. Okay. Okay, so I'm closing this. Yeah, so I would agree with probably the majority here that left ventricular function is reduced. And I would also think it is somewhere between mild to moderate. So very good. I think all of you seem to be really learning something from this course and from this experience, because the way you quantify left ventricular function is just the way that I would. And of course, it's very difficult, eyeballing. Of course, it's also possible to use the Simpson method. With the Simpson method, I got an ejection fraction, as a matter of fact, of 48%. Okay, 48%. Let me go back. Let me go back to the. Okay, I've got it. Okay, sorry, I'll keep on forgetting to show you the images again. Okay, here you are with the image. Well, so I got an ejection fraction of 40%. But if you look at, for example, the fractional shortening with M mode, we got a fractional shortening of 30%, which is still normal. Remember, the lower range is somewhere in the range of 27 to 28%. In this case, it's 30, so it's above that range. So if you would solely look at fractional shortening, you would certainly overestimate left ventricular function. So eyeballing is something that I would propose to do. And in reality, this patient does have reduced left ventricular function. Like I said, ejection fraction was 48, and the patient then was taken off chemotherapy, and she improved. Which chemotherapy did she have? She had a molecular targeted drug which is called sunitinib, which is a tyrokinase inhibitor, which is used for kidney tumors, and a chemotherapy which also has cardiotoxic effects, maybe not as severe as other chemotherapeutic agents, but nevertheless, this is the proof in this patient. So she was taken off the chemotherapy, and she improved only 3 or 4 weeks later. And then we had the big decision if we should not put her on chemotherapy again, but this is still something we haven't decided on yet. Yes, two questions that I want to answer. First of all, Alan made a statement about septal motion, and I agree completely with him that the septal motion is not normal in this patient, because if you look at the motion of the left ventricle, you can see a rotating motion. And this is explained also because the patient has a broader QRS complex. This broader QRS complex leads to this abnormal septal motion, and in this case, you probably tend to underestimate true contractility. So in these patients, it's very difficult to really eyeball left ventricular function. So I take this under consideration. For me, if I look at this ventricle, I would probably say it's moderately reduced, but then I consider that there's also abnormal motion, so I say maybe, okay, it's mild to moderate. And then one other thing that is certainly true, Emmanuel made this comment, you have a hyperdynamic compensatory motion of the posterolateral wall, which is sometimes something you see very frequently in patients who have a myocardial infarction, where you have an inferior infarct, for example, and the anterior wall seems to compensate for it. So this must also be considered. And again, if you look at this view alone, it is not enough. You have to look at all the different views. And if you look at all the views together, you will come to the conclusion that left ventricular function is certainly not normal in this patient. One last thing that I would also suggest, if you are in doubt, a very simple trick. As a matter of fact, I'm going to post a case sooner or later on the newsletter, which demonstrates what I'm going to say right now, namely that you can use a little ball and have the patients do hand grip maneuvers while you do the echo. And when they do that, you can see that the contractility actually increases during this maneuver. And this sometimes gives you, I would say, a little stress echo you can do on the side, which does not take much time, but still gives you some information on whether or not left ventricular function is normal or not, at least during a hand grip maneuver. Okay, so again, to summarize this case, not easy to determine what left ventricular function is. You have to use many different modalities. You have to look at M-mode, you have to look at eyeballing, you can even look at tissue Doppler and other things. Piotr asked, does M-mode overestimate left ventricular function? Well, this is a difficult answer because it depends on the geometry of the left ventricle. Because if you look at the M-mode, usually only looks at, first of all, a specific segment of the left ventricle. For example, if you go with the M-mode right through here, you will only look at this segment and you will not see, for example, the apical segment. So this is one problem of M-mode. The other is that if you have a small ventricle, the motion of the walls will usually be more compared to a patient who has a large ventricle but the same ejection fraction. So yes, if you have a small ventricle, the M-mode will also overestimate left ventricular function. Good.